So now remember, we got to go through all 3 steps. After you've pulled out the plasma, formed your filtrate, aka did glomerular filtration. Remember, as soon as you pull out that plasma, you're going to go on to the second step. You're going to take a lot of what's in the plasma and put it right back into the blood. And we're doing it in the renal tubules. So you remember, we call that process tubular reabsorption. Tubular reabsorption is just when you take stuff out of the filtrate and put it back into the blood. That's tubular reabsorption. So we're going to have to talk about, how do you do that? How do you now take things out of this filtrate, this filtered out plasma, and put it back into the bloodstream? Well, you're going to have to do it through the cells forming the tubules, through these simple cuboidal epithelial cells. And so we're really talking about cellular transport. So like always, we got to remember AMP1. Remember when you talk about cellular transport crossing the plasma membrane, remember we talked about it in 2 major groups. Remember there was something called active transport and passive. And remember, the major difference between active and passive transport is just, do you need energy? Remember, if you need energy to cross the plasma membrane, that's active transport. And if you don't need energy to cross the plasma membrane, that's passive. So when we talk about doing tubular reabsorption, there's going to be active tubular reabsorption. You're going to need energy. And there's going to be passive tubular reabsorption. You're not going to need energy. Okay, so remember, you know a lot about AMP2 already from AMP1. We just got to remember. And you might have even talked about how chemicals could pass through or between cells. If not, don't worry, we're going to mention it now. Turns out there are 2 major routes, literally a pathway, for chemicals to take to pass through these cells. There's something called transcellular transport and something called paracellular. Remember, don't be intimidated by the names. They tell you what's going on. They're a pathway for chemicals to take through cells. They're a route. To be transcellular is like transcytosis. Here's AMP1. Remember, transcytosis is when you enter the cell on one side, go through the cytoplasm, and come out the other side. Remember, that was transcytosis. That's basically what you're doing in transcellular transport, in that transcellular route. You're entering the cell on one side, going through the cell, and coming out on one side. And when it comes to the sides of the cell, we're talking about the cells in a tubule, either a proximal convoluted tubule, distal convoluted tubule, nephron loop. We're talking about a tubule. I'm relating this to lab. Remember, this is going to be simple cuboidal epithelium. We got to remember AMP1. Remember, your simple epithelial tissues lay themselves out flat. And when you lay your cells out flat on a surface, we could designate a top and a bottom. And we give them names. Remember, the top surface is called the apical surface, and the bottom surface was called the basal surface. This is what they're mentioning on this slide here when we talk about transcellular and paracellular routes. In the transcellular route, you're going to enter the cell on one side, cross it, and come out the other. Well, when it comes to these chemicals using the transcellular route, well, they're going to come from the lumen side, and the lumen side is the apical side. So they're going to leave the lumen and go through the cells, starting with the apical side, the surface side. They're going to pass through the cell and come out the bottom, which is called the basolateral side, or the basolateral membrane. That's all that's happening. They're just going through the cell in the transcellular route. But again, there are other routes to take. There's the paracellular route. Para, because you're going between cells. You're not going through any plasma membranes. You're literally going through or going between the cells. Okay. And so you'll tend to see this in cells held together by things like leaky junctions. Junctions that are not tight junctions. Remember, tight junctions prevent leaks between cells. So you will not use the paracellular route in a tight junction. But other junctions are not held together tightly. They'll have some leaks. So you may be able to use paracellular routes. But these are just 2 possibilities on routes chemicals, compounds could take when you're doing reabsorption. And who does what? Turns out, if you are allowed to go through the plasma membrane, think back to AMP1, remember things with the charge typically cannot pass through the plasma membrane directly, so they probably won't do transcellular route. So you might have to do things like a paracellular. Oh, remember what things had a charge? Well, you had a charge if you were the result of a nonpolar covalent bond, like water. Remember, water has charges, a slightly positive end and a slightly negative. And then there's the ions, calcium ions, magnesium, potassium, sodium. They're all ions. They're all charged particles. They're going to need the paracellular route. You know this. You just got to think about AMP1. So that's all you're seeing in this picture. You could go through a cell, starting from the lumen side, the apical side, going through the cell and coming out the basolateral side, which on that side you'll have the blood vessels to get dumped into. That's the transcellular route. Or you can simply slip between the cells. As long as it's not held together by tight junctions, you'll be able to slip between the cells and enter the bloodstream. That's your paracellular route. And we know you could either use energy to help you to do it or not use energy. It could be active or it could be passive. So now that we kind of know the basics on how things are going to be reabsorbed, now we got to talk about what's reabsorbed. As we go through these renal tubules, I want you to know what gets reabsorbed and secreted in each part of the renal tubule. And like usual, we're going to take our time going through it, but there's a slide that summarizes it all. It's slide number not 76. It's the figure 2617. Figure 2617 shows you a nephron, and it shows you the renal tubules, and in the little blue boxes, it's showing what's reabsorbed, and in the green boxes, it's showing what's secreted. Basically, know this little graph. It's figure 2617. That's going to help you. But we're going to go through it all slowly. Just keep in mind, you got to know what's getting reabsorbed and what's getting secreted in the different parts of the renal tubules. And so we're going to begin with some reabsorption because that's what we're talking about, tubular reabsorption. Turns out one of the things you're going to have to reabsorb, one of the things you're going to have to put right back into the bloodstream is sodium. You're going to basically reabsorb all the things your body needs. And we've seen by now in AMP 1 and 2, you need sodium. You need sodium to do things like make electricity, aka an action potential. You need sodium to help you to move. You need sodium to help send signals. Sodium's important, so you're going to keep it. So you're going to put it back into the bloodstream. You're going to reabsorb it. And it's going to get reabsorbed along the apical surface and the basolateral surface. A cell is going to be sucking and absorbing sodium along its lumen side and the blood vessel side, the apical side and the basolateral side. Why? Why are cells taking in sodium on both sides? Well, we got to talk about that. First, we're going to start off with the actual bottom side, the side that faces the blood vessels, the basolateral side. Turns out you'll be transporting sodium across the basolateral membrane using primary active transport, and you might already know how. Had to deal with your resting membrane potential. Think back to AMP1. Remember, there was a sodium-potassium ATPase that helped to restore the resting membrane potential whenever you made an action potential. Remember your sodium-potassium ATPase would usually kick out 3 sodiums for every 2 potassiums it lets in. And remember, it's called an ATPase because it uses energy. This is how you're transporting sodium across the basolateral membrane. You're kicking out 3 sodiums for every 2 potassiums you let in. And you know why you're kicking out the sodium. You're kicking the sodium out of the cell to kick it into the bloodstream because you're doing reabsorption. We're talking about the basolateral side. This is how you're getting the sodium out of the cell and into the bloodstream. You're just using your sodium-potassium ATPase. You're doing primary active transport. And so this is how you're going to be pumping out tons of sodium from the cell into the bloodstream. But how did the sodium get into the cell? Well, it got into the cell at the apical membrane. How do you do that there now? Well, you're going to transport sodium at the apical surface of your cells using secondary active transport as the major mechanism. Remember, think back to AMP1. Remember, in secondary active transport mechanisms, your pumps, your protein channels are not using ATP directly. Remember, in secondary active transport, you're typically relying on things like an electrochemical gradient. That's what's happening here. You're able to suck sodium into the cell at the apical surface because of all the work you're doing at the basolateral surface. Remember, at the basolateral surface, at the side facing the blood vessels, you're kicking out sodium. So the cell is basically becoming a vacuum for sodium at the apical side. And I think you're flushing all the sodium at the basolateral side. So now you're practically a vacuum for it at the apical side. Why? Because you're kicking out all that positively charged sodium. Remember, this electrochemical gradient is established. Remember, this sodium-potassium ATPase, because it kicks out 3 sodiums and only lets in 2 potassiums. Remember, this helped to establish your resting membrane potential, or you became more negative on the inside of the cell. Well, if you're more negative on the inside, towards the top, towards the apical surface, positively charged things are going to want to come in. This is how you're creating that vacuum. This is the electrochemical gradient established by the sodium-potassium ATPase located at the basolateral membrane. This is secondary active transport. Thanks to all the energy being used at the basolateral membrane with the sodium-potassium ATPase, you've established an electrochemical gradient where you're more negative on the inside with very little sodium. So at the apical surface, sodium is going to rush into the cell. And even to help create more of this sodium vacuum, some of that potassium that you let in actually leaks out. So even though you are letting some positive stuff in, it's leaking out as well. And so that cell is negative on the inside. There's an electrical and a chemical gradient that's attracting sodium into the cell at its apical surface. So it's really all the work at the basal surface that is driving the movement at both sides, the basal and apical sides. And that's how you're going to reabsorb sodium, mainly. You can also reabsorb a little sodium with some facilitated diffusion as well. Remember, diffusion is just things going from where there's a large concentration of solutes to low. In this case, there's a lot of sodium at the apical surface and little inside because you're kicking it out at the basolateral surface. So they'll diffuse inside, but it has a charge to it. So it's not going to be able to directly pass through the membrane. You're going to need a protein channel to assist. Remember, if you need a protein channel to assist in diffusion, that was facilitated diffusion. That is another way sodium could enter the cell. But again, that's not the only thing you're going to be able to reabsorb. Turns out, like usual, wherever sodium goes, water is going to follow. So when we talk about electrochemical gradients, when we talk about moving solutes like sodium or possibly sodium chloride, well, things like water are going to follow. And if you recall your membrane transport, there were other ways to transport things across the membrane. There was something called co-transport. You might have also called this uniport transport, sending things in one direction, sending more than one thing in one direction. Co-transport is when you send multiple things in the same direction. Turns out some things use co-transport with sodium. What things are going to enter the cell and get reabsorbed with sodium besides water? Well, it's going to be things like glucose, amino acids, vitamins, and other ions. So you're doing reabsorption of a ton of stuff. Sodium, water, glucose, amino acids, all the things your body needs. You need glucose for energy. You need amino acids to make proteins. You need ions like sodium and potassium to help you to carry out daily activities, as well as vitamins. So you're going to reabsorb all these nutrients that your body normally needs, and you're going to do it via co-transport with sodium. Except for water. Movement of sodium and other solutes, we already know, will attract water. We're talking about osmosis. Remember, water will move from an area of low solute concentration to an area of high solute concentration through a selectively permeable membrane. Remember, that was osmosis. We got to talk about how water will move during tubular reabsorption. It's just following sodium. It's going from where there's little sodium to where there's a lot. It's just going to follow it. And it's going to follow via osmosis. But remember, water has a charge, so it cannot directly go through the plasma membranes. It's going to need a protein channel. It's going to need an integral protein. Integral proteins, aka protein channels that allow water to pass through the plasma membrane, are called aquaporins. I want you to know, what is an aquaporin? An aquaporin is just the membrane protein channel, aka an integral protein that allows water to pass through the membrane. And it turns out you always have aquaporins in your proximal convoluted tubule. So we say your proximal convoluted tubule does obligatory water reabsorption. Obligatory meaning you kind of have to, you're obligated to. So your proximal convoluted tubules will always reabsorb water. They are obligatory to reabsorb water. Why? They always have aquaporins. They always have these protein channels to allow water to pass through the plasma membrane and get reabsorbed. So, in addition to reabsorbing sodium, glucose, amino acids, ions, and vitamins, your proximal convoluted tubule will reabsorb water as well using these aquaporins. But you'll also do reabsorption in other places. You'll primarily do water reabsorption in your collecting ducts. But you'll see as we go through this chapter, and you'll actually see right now on this slide, you'll reabsorb water in the collecting ducts only if it's told to by a hormone. Hormone you've heard about already. It's antidiuretic hormone, sometimes referred to as vasopressin. Antidiuretic hormone, remember, that allowed you to hold on to water by keeping you from peeing. Remember, to be an antidiuretic means you're going to hold on to water by not peeing. And you're going to hold on to water, now you know, because antidiuretic hormone forces aquaporins to get inserted into the plasma membranes of the cells forming the collecting ducts. Meaning when you're dehydrated, you'll release antidiuretic hormone, ADH, and will go to the kidneys and go to the collecting ducts and say, hey, you need some aquaporins because you need to reabsorb water because you're dehydrated. You don't need to pee it out. When you force the collecting ducts to insert aquaporins using ADH, that's a type of what we call a facultative water reabsorption. Facultative means you'll only do it if. You'll only reabsorb water in the collecting ducts if you are inserted aquaporins thanks to the hormone antidiuretic hormone. So you're seeing you're going to reabsorb some things in multiple places. You now know you at least reabsorb water in the proximal convoluted tubules and the collecting ducts. But you'll do a lot of water reabsorption quickly in that first part, the proximal convoluted tubule. And because of that, you're going to see some kind of consequences. When you do all this water reabsorption in the proximal convoluted tubule, what's left in the tubule, the filtrate, is now highly concentrated. Once you reabsorb water, once you pull out the water from the filtrate will become concentrated. Makes sense because you're taking out the water. But turns out things also like to follow water. Things like fat. So when you're reabsorbing water and concentrating the filtrate, you'll also reabsorb some fat and things that get dissolved in fat, which can be a problem for some medication. Some medication, your body will try to flush it out in your urine, but because it's fat soluble, it can mix and dissolve in fat, you'll actually reabsorb it with some water and it'll stay in your body longer. Remember, if we know how the body works, we could take advantage of it. So that's all you're seeing on this slide. It's kind of summarizing everything we talked about. Some things will move via primary active transport. Think that's sodium, potassium, ATPase at the basolateral membrane. That's what you're seeing in red, label number 1. And because of that, that will establish an electrochemical gradient for sodium, which will drive your secondary active transport at the apical surface. That's what you're seeing at number 2. As that sodium is coming in, things could come in with it at the apical surface, things like glucose, amino acids, etc. Remember, that was co-transport. That's number 3. Remember, things like water will also want to follow the sodium via osmosis, but they're going to need aquaporins to help them to do it. They're going to need some facilitated type of osmosis. Remember, that's number 4. It's basically a type of protein transport because you're using a protein, the aquaporins. Remember, wherever water moves, fats and things dissolved in fats will help or kind of follow along. That's what you're seeing in number 5. And don't forget things like charged particles, other ions, could simply use paracellular diffusion. They'll go between cells. That's what you're seeing in number 6. So 1 through 5 are all types of transcellular transports because you're going through the cell. And so that's how you're going to do a lot of reabsorption, primarily in the proximal convoluted tubules. As soon as you pull out the plasma, right away, you're going to have to dump all these things back into the bloodstream because you're going to need to do it. And you're going to do it in the proximal convoluted tubules. And when it comes to transporting things, like always, there are limits. You can't transport an infinite number of things across the plasma membranes of your tubular cells, of your simple cuboidal cells forming the tubules. Why? There's something called a transport maximum. It's the maximum amount you could reabsorb a substance. And it's all related to how many of those proteins or how many of those solutes you need to carry. We already know if you increase the concentration, you're more likely to do things like diffusion and increase diffusion. So if you have a higher concentration of solutes, well, your transport max, you'll more likely be able to hit your transport max. But in addition to concentration numbers that could have an influence on your ability to hit your transport max, it's also the number of carriers. We saw a lot of things need to get moved using these integral proteins, these protein channels. So the number of carriers, the number of protein channels you have for these solutes will also matter. And that tends to matter a lot. If you saturated all your carriers, if you use the maximum number of protein channels you could use in your plasma membrane, you will definitely hit your protein max or your transport max. So there's a limit to how much you could transport. It has to deal with how much you need to transport and how many carriers you have for it. So now that we know how we're moving things, thanks to our little example at looking at some proximal convoluted tubule and distal convoluted tubule areas, now we know how things are moving. We could go back and talk about what we're moving. Remember, for each part of the tubules, you got to know what do you reabsorb and what do you secrete. Remember, it's on that one figure, but we're going through it in the slides. So let's start off in order. Remember, after the renal corpuscle, after the glomerulus, you'll send the filtrate into the proximal convoluted tubule. And I mentioned earlier, this is where you're going to do most of your reabsorption. Your body's going to try to reabsorb all your nutrients here, all the important things you're going to need. Like I mentioned earlier, it's going to be things like glucose, your amino acids, a lot of your ions, vitamins, and water. All that's going to be reabsorbed in the proximal convoluted tubule. But there are transport max. So on average, do we know some percentages how much of these things we're going to be reabsorbing? Yes. Turns out about 65% of your sodium and water gets reabsorbed in the proximal convoluted tubule. That's more than half. So as soon as you made your filtrate, as soon as you pulled that plasma out, you took more than half of the sodium and water and you put it right back into the blood. Remember, your kidneys filter over 100 liters of fluid, but you do not have 100 liters of fluid in your body. It's because you're putting a lot of this fluid back. You're just recycling this same liquids. So about 65% of sodium and water gets put back, and in addition to the things that follow them, like ions, glucose, amino acids, vitamins, and some acids, uric acid and urea. We'll see these a little later. Just know these things get reabsorbed. In the proximal convoluted tubule, know you're going to reabsorb sodium, water, glucose, amino acid, irons, vitamins, uric acid, and urea. All that, almost everything, gets reabsorbed in the proximal convoluted tubule. And so because of that, there's not that much to reabsorb and secrete in the other parts, which is good. So think almost everything in the proximal convoluted tubules and a little few extra things everywhere else. So let's go on. After the proximal convoluted tubule, the next part is the nephron loop. And remember, in order, you're going to go through the descending limb going down towards the medulla, then the ascending limb coming back up towards the cortex. And it turns out each half of the nephron, each limb reabsorbs different things. They actually reabsorb the opposite things. They reabsorb and secrete the opposite things. Why? It has to deal with how things could pass through the plasma membranes. In the descending limb, water could leave a cell. It could get reabsorbed. But solutes cannot cross, so they will not. While it's the opposite in the ascending limb. Water in the ascending limb cannot leave, but solutes could leave a cell. So, because of this, we could tell the reabsorption. Your descending limb, because water could move, will reabsorb water. And your ascending limb, because solutes could move, will reabsorb solutes, like sodium and potassium. And we know they're going to reabsorb solutes like sodium and potassium because of the carriers in the plasma membrane. Remember, you need these protein channels to help you to do things like co-transport. And it turns out there's a co-transporter, a particular one called a symporter. It's going to allow you to transport sodium, potassium, and chlorine. The sodium, potassium, chlorine symporters. Sodium, potassium, chlorine symporters will allow you to reabsorb sodium, potassium, and chlorine. And these symporters are in the ascending limb. That's why these solutes can leave cells in the ascending limbs, because they have the carriers for them. It's all about whether you have your carriers to be able to allow you to pass through the plasma membrane. So if you look on that summary figure 2617, when you look at the ascending limb, you'll see those things in the blue reabsorbed box. You'll see the sodium, potassium, and chlorine getting reabsorbed. Now you know why, because there are symporters to help with the transport. All right, so that's what's getting reabsorbed in the nephron loop. Keep it simple. In the descending limb, water gets reabsorbed. In the ascending limb, it's going to be ions, particularly sodium, potassium, and chlorine. Keep going. After the nephron loop, remember, you're going to come to the distal convoluted tubule. And after the distal convoluted tubule, enter, drain into the collecting duct. Remember, you already know the pathway. Turns out the distal convoluted tubule acts a lot like the collecting duct. How? Turns out their reabsorptions, both the distal convoluted tubule and the collecting duct's reabsorption, is driven primarily by hormones. We already saw the collecting duct will reabsorb water if there is antidiuretic hormone to force the insertion of aquaporins. Turns out the distal convoluted tubule will also have a hormone that will tell it what to do. And again, it's a hormone we've already seen. It's aldosterone. You already know. One more time. We already know aldosterone will promote sodium reabsorption. So you hold on to sodium and water, and it will promote potassium excretion. It's doing it in the distal convoluted tubule. How? Turns out aldosterone in the distal convoluted tubule will help you to promote synthesis of some of these protein channels. It will force the distal convoluted tubule to make protein channels to help with reabsorption. And we actually know which protein channel. Aldosterone will help you to make that sodium potassium ATPase at the basolateral surface. Why? We already know what that's going to do. That sodium potassium ATPase at the basolateral surface, the basolateral membrane, will kick out that sodium from the cell and dump it into the bloodstream. This is how you're helping to reabsorb sodium in the distal convoluted tubule. Aldosterone just forces it to make those basolateral sodium potassium ATPases. And you'll kick that sodium into the bloodstream, aka reabsorb it, while taking that potassium and pulling it into the cell. And because there's lots of it in the cell at the apical surface, it will leave into that lumen and get dumped into the filtrate, which you'll pee out. And remember, wherever sodium goes, water will follow. So you'll hold on to the sodium and water, increasing your blood volume and your blood pressure overall. That's what aldosterone is going to do. It's going to increase sodium and water levels, which will increase blood volume and blood pressure, while at the same time causing your potassium levels to drop. Now we're putting it all together now. Now you know the full picture of how aldosterone works. But it turns out aldosterone and antidiuretic hormone are not the only hormones that have a say in the distal convoluted tubules and the collecting ducts. There are other hormones. Like these two we see on this slide here, atrial natriuretic peptide and parathyroid hormones. Like usual, you already know atrial natriuretic peptide is a hormone coming from the heart. Remember, the heart made that to kind of get a rest by dropping the blood pressure. How does atrial natriuretic peptide drop the blood pressure? Well, it's gonna get you to excrete sodium. Remember, it's almost the opposite of aldosterone. It's going to cause you to drop your sodium levels, get rid of sodium. And wherever sodium goes, water will follow. So you will decrease your water levels in everything, including the blood. So your blood volume will drop. And if your blood volume drops, your blood pressure will drop and the heart will kind of get a rest. So that's atrial natriuretic peptide. And it's getting you to release or secrete the sodium in places like your collecting ducts. And there's one more. It's parathyroid hormone. Again, you know this one too. Think back. Remember, parathyroid hormone helped you to raise your calcium levels whenever they were too low. How does the kidneys help? Remember, you could pee out calcium. It's an ion. You could pee it out. Well, if your calcium levels are low, you're not going to want to pee it out. You're going to want to do calcium reabsorption. Turns out parathyroid hormone causes you to increase calcium reabsorption, specifically in the distal convoluted tubule. So now you know how these hormones are working using the kidneys. Know these hormones and the effects they're going to have. Antidiuretic hormone will cause you to increase aquaporin numbers in the plasma membrane to allow you to increase water reabsorption. Aldosterone, remember, will cause your distal convoluted tubules to increase production of basolateral sodium potassium ATPases to allow for sodium and water reabsorption, to increase blood volume and blood pressure, while at the same time causing potassium secretion, so your potassium levels will drop. Remember, atrial natriuretic peptide is coming from the heart. It's helping you to excrete or secrete sodium and water, so your blood volume will drop and your blood pressure, so the heart will get a rest. And parathyroid hormone will increase calcium levels by increasing calcium reabsorption in the distal convoluted tubules. So make sure you know what gets reabsorbed and what's secreted in each part of the renal tubules. It's all on this one figure. Figure 2617 shows you the renal tubules. Remember, in the blue boxes are what's getting reabsorbed, and in the green boxes is what's getting secreted. And again, just to help reinforce it, these next slides are just tables. Table 25.1 is just highlighting each segment of the renal tubules, again, highlighting what's getting reabsorbed. That was second step. That was tubular reabsorption. Remember, to finish off making urine, you had to do one last step. We got to pump things into the filtrate. You got to take things from the blood and put it into the filtrate so you form your urine and pee it out. Remember, when you take things from the blood and now put it into the filtrate, we're basically doing a reabsorption in reverse. Remember, that's called tubular secretion. You're going from the blood into the filtrate, into the tubule. Turns out it's very similar to tubular reabsorption in terms of location. Turns out, remember, we did most of your tubular reabsorption in the proximal convoluted tubules, and every other part of the tubules kind of just fine-tuned it, did a little extra. Well, it turns out you're going to do most of your tubular secretion also in the proximal convoluted tubules. So as soon as you pull out that plasma, that filtrate, now you know you're going to take a lot of that stuff out of the filtrate, put it in the blood, reabsorption, and you're going to take some stuff from the blood and put it in the filtrate, secretion. You're going to do a lot of it in the proximal convoluted tubules. That's why they have so many microvilli. They're doing tons of secretion and reabsorption. So again, you got to know now what's getting secreted. That same figure 2617, remember it told you what got reabsorbed and secreted. So we're going to do it again in these slides for secretion, but it's all summarized in terms of what's getting secreted on that one figure 2617. So let's go through it. So what are some things you're going to secrete? Well, you're going to secrete things your body doesn't need, because when you secrete it, you'll eventually pee it out. So you think you're going to pee out things you don't need. What are some things you don't need? Well, it's going to be some things like acid to help maintain your body's acid base homeostasis. Remember that capital H with a superscript positive sign? Remember that was just positively charged hydrogen. Remember that was just basically acids. You're going to pee out some acids. You'll also pee out ammonia. That nitrogen and hydrogen, that's ammonia. You'll also pee that out. As well as some other things, some other organic acids and bases, depending on your acid-base levels, as well as some other things like creatine. And we already know we could already secrete potassium, thanks to our sodium-potassium ATPases. So, what else is going to go on? How do we do this? Why are we doing this? Well, I kind of told you you're going to be doing secretion to get rid of stuff. You're going to try to eliminate undesirable substances. Turns out a lot of those acids, certain acids like urea and uric acid, are undesirable. Things are like ammonia are undesirable in large quantities. So your body's going to try to get rid of it, as well as some drugs or metabolites that might be in your system. You'll secrete these things. Try to get rid of it. Okay. And again, it's all summarized in this figure here. So before we continue, we could just break down the image. So again, as soon as you pull out that plasma, send it into the proximal convoluted tubule, or you'll reabsorb the things you need. Things like sodium, water, glucose, etc. But you'll secrete things you don't need, like drugs, acids, and ammonia. That's all going to get secreted in the proximal convoluted tubule. Remember, in the descending limb, only water can move and it gets reabsorbed. While in the ascending limb, remember, it's solutes that tend to move. So you remember, it's your symporter, sodium, potassium, chlorine symporter. So sodium, potassium, and chlorine get reabsorbed in the ascending limb. But it turns out you'll secrete something in the ascending limb. The ascending limb will secrete urea. Remember, that's also an undesirable. You don't really use a lot of urea besides your urea cycle, which will end in you getting rid of urea. And you're getting rid of it in your urine because you're secreting it in the ascending limb of your nephron loop. And after the nephron loop is the distal convoluted tubule. You already know that's driven by hormones like aldosterone, which could cause potassium secretion. Remember, aldosterone holds on to sodium, gets rid of potassium. So you're secreting potassium in the distal convoluted tubule thanks to aldosterone. And the collecting duct is also driven by aldosterone, so you could also secrete potassium in the collecting duct as well. So this one slide, remember, summarizes what gets secreted and what gets reabsorbed. So that's basically the major functions of the kidney, and it's largely related to you making urine. And you happen to do it in 3 major steps. Glomerular filtration, pull out that plasma, form the filtrate. Tubular reabsorption, take a lot of what's in that filtrate, put it right back in the bloodstream. And tubular secretion, take some things you don't want and dump it into the blood, dump it into the filtrate for you to pee out. That's it. So now you know about making urine, so now we could talk about regulating it. And a major thing that we regulate when it comes to urine is regulating urine concentration. Remember, you could have dilute urine when you're overhydrated, and you could have concentrated urine when you're dehydrated. So we're basically going to have to talk about that. So how does the kidney vary the concentration of the urine? We're really talking about concentration, but when you're reading, you might see the word osmolality. Osmolality is just the number of solute particles per a certain amount of water, meaning how much of a solute do you have in water. It's basically talking about concentration. The more solute you have in the water, the more concentrated it is. The less solute you have in water, the less concentrated. So whenever you see osmolality, you could simply think concentration, if that helps. And so we're going to talk about it. How do you vary the osmolality? How do you vary the concentration of your urine? You know this probably anecdotally from your personal life. You know when you drink a lot of water, you're going to pee a lot. And if you happen to look at it, when you're drinking a lot of water, look at the urine, it looks almost clear, almost like the water. It's because it's dilute. You make dilute urine when you're overhydrated. And you might notice when you're dehydrated and you urinate, the urine looks a very strong yellowish amber color. It's because it's now dehydrated, not that much water. It's concentrated. So we got to talk about how do you do it. Turns out you're going to concentrate or dilute your urine using what we call a countercurrent mechanism. Don't be intimidated by the name. Remember, names in anatomy are always here to help. It's called a countercurrent mechanism for a reason. A countercurrent just tells you the name. Counter means opposites, and a current, as in a flow. This is a countercurrent is talking about 2 flowing fluids that are going in opposite directions. Think 2 streams flowing in opposite directions. And it happens that these 2 streams are connected by a hairpin turn, a U-turn. So think 2 streams going in opposite directions connected on one end by a turn. All right, that's a countercurrent. Turns out you have countercurrents in your kidneys. You have streams of fluid, either filtrate or blood, going in certain directions that are sometimes going in opposite directions connected by a hairpin turn. Oh, where did we see a looping structure? Oh, maybe it was the nephron loop. Yes. So as we're talking about these countercurrent mechanisms, we're going to have to talk about the nephron loop. Because we saw in the nephron loop, there's the descending limb on one side, and there's the ascending limb on another side. And they're connected by that hairpin turn at the bottom of the loop. That's where we're going to have some of our countercurrent mechanism. It's going to be a specific type of countercurrent mechanism we call the countercurrent multipliers. But we also saw another kind of linked pathway of fluids connected by a hairpin turn. Where else did we see looped structures? We saw it in blood vessels sitting on top of the nephron. Sitting on top of our juxtamedullary nephrons, we saw vasa recta. Just go back to the pictures. Go look at a vasa recta. It will look almost just like a nephron loop. You're seeing a blood vessel with a loop at the bottom connecting blood flowing in opposite directions. That is also another countercurrent. In this case, it's called the countercurrent exchanger. Turns out these countercurrent mechanisms are helping you to concentrate your urine. There are two types. There's the countercurrent multiplier. This is just us talking about the nephron loops, the ascending and descending limbs of the nephron loops. And there's something called the countercurrent exchangers. This is just us talking about the ascending and descending limbs of the vasa recta, of the blood vessels. They're going to work together. And they're going to work together to help you to either concentrate or dilute the urine. So let's see how that happens. So I mentioned both the countercurrent multiplier and the countercurrent exchanger are going to work together. And they're going to work together to help establish or create and maintain a medullary osmotic gradient. What is that? Your medullary osmotic gradient. It's just a concentration gradient varying between the cortex and medulla. How? We're basically saying the cortex is dilute, not that concentrated, and the medulla is highly concentrated. And we know the numbers. You do not need to know these numbers, but just to help, the cortex is concentrated. It has about what we call 300 milliosmoles. Remember, osmol or osmolality, think concentration, and it's only 300 milliosmoles. While in the medulla, it's 1,200 milliosmoles. The medulla is way more concentrated than the cortex. How? It's thanks to this medullary osmotic gradient created by our countercurrent mechanisms, created by a countercurrent multiplier and exchanger. And as we go through this, you're going to see it's the countercurrent multiplier. It's the ascending and descending limbs of the nephron loop that's going to make the medulla more concentrated and the cortex less concentrated. While the countercurrent exchanger, the ascending and descending limbs of the vasa recta, are going to help to maintain this difference. It's going to keep it going. It's going to preserve it. Why? Why do we need the medulla to be more concentrated and the cortex to be less? Who's going to take advantage of that? And how is that going to lead to dilute or concentrated urine? It's going to be the collecting ducts. We're using the countercurrent multiplier and exchanger to create this difference in concentration between the cortex and the medulla so that the collecting duct could use it to vary the concentration of the urine. No, you do not need to know it in more detail besides that, but we're going through these slides. That's all you're seeing in this picture here. So in the top image, you're seeing the nephron loop in yellow. You're seeing the ascending limb on the left and the, descending limb on the left and the ascending limb on the right. That's going to help to establish the difference simply by doing their normal job. So let's go through it. How does the countercurrent multiplier, how does the ascending limb and descending limb help to make the medulla concentrated? Well, just think about what gets reabsorbed and what gets secreted in the ascending and descending limbs. We already know it's a countercurrent because the fluid, the filtrate flowing in the ascending limb is going the opposite direction of the descending limb. They're going in opposite directions. So we already know that. So this is a countercurrent. But how is that going to lead to the medulla getting more concentrated? Well, it's just them doing their normal job. We already know the ascending limb will let solutes pass, while the descending limb will let water pass. So it's just them doing their job. As the filtrate is going through the descending limb, water will get reabsorbed, and some of it, even though it's getting reabsorbed into the bloodstream, some of it will stay in the interstitial fluid. It will stay in the environment around the cells. And something similar happens in the ascending limb. When you reabsorb that sodium, potassium, and chlorine, some of it will stay in the interstitial fluid around the cells. It will stay in that extracellular environment. And this will happen for the entire length of the nephron loop. Your ascending limb is actively putting that sodium and chloride into the interstitial fluid as it's making its way into the bloodstream, while that descending limb is constantly putting water into the interstitial fluid as it's making its way to the bloodstream. And they kind of interfere with each other. Every time the ascending limb drops sodium into the interstitial fluid, that concentrates it. So some water, as it's getting reabsorbed, will stay in the interstitial fluid too, because it's attracted via osmosis. And they'll kind of fight each other, where the ascending limb will make the filtrate salty and the descending limb will try to dilute it. And this is happening throughout the nephron loop. And it turns out, as you go through the nephron loop, this difference gets multiplied. It happens over and over again. It reinforces itself. So that closer to the cortex, closer to where the descending limb begins, which is in the cortex area, well, it's going to be more dilute. That's why the cortex has about 300 milliosmoles as that somewhat concentration. While closer to where the ascending limb begins, which is closer to the medulla side, that's where you're kicking out all the salt, well, that's going to be more concentrated. That's why the medulla's osmolality is about 100 or 1,200 milliosmoles. This is how you establish that medullary osmotic gradient. It's just the nephron loop doing its job, and you happen to spill out some of these contexts into the interstitial fluid, and it will affect the concentration in the cortex and the medulla. That's all. It's just them doing their normal job, and some stuff is getting stuck in the interstitial fluid. And that's all you're seeing in this image here. Water gets pulled out on the left side in blue, descending limb, and the sodium chloride gets pulled out on the right side in red in the ascending limb. And it gets multiplied. It gets more intense as you go down into the medulla. And so that's how you establish the gradient. It's just the nephron loop doing its normal job. But your body will automatically try to fix this. So we're going to need a way to keep this going, to keep your body from reestablishing homeostasis. We need to maintain this medullary concentration, this medullary osmotic gradient. Remember, you help to maintain the gradient with the countercurrent exchangers, with the vasorecta. This is why there are blood vessels, besides doing reabsorption and secretion. This is why there are blood vessels here. It's helping to establish or maintain this gradient. And now we got to talk about it. Now we got to talk about the countercurrent exchangers. How do the vasorecta help to keep the cortex dilute and the medulla concentrated? So again, it's a countercurrent. So your vasorecta has fluid, in this case blood, moving in opposite directions in its ascending and descending limbs, and they're connected by a hairpin turn. And you already know your blood vessels are helping with the reabsorption and secretion. They'll allow water and solutes to cross the plasma membranes of the cells, forming these tiny capillaries as well. And they're going to be permeable to the same things as the nephron loop. They're going to be permeable to both water and those solutes. So it turns out those vasorecta, the countercurrent exchangers, are going to help to maintain this medullary gradient simply by removing any water or salt if it needs to. It will help to prevent any removal or kind of helping to reestablish homeostasis of salt in the interstitial fluid as well as water. And it could do it because it's just as permeable as the nephron loop. And it's going to be focusing a lot on reabsorbing any extra water. It wants the medulla to stay concentrated. So it will help to focus on reabsorbing any water that might be diluting the medulla. So if you were to look at the blood in the vasorecta, when you look at the descending limb where it begins and the ascending limb where it ends, the volume of blood is going to be different. Turns out the volume of blood at the end of the vasorecta, at the end of the ascending loop, will be greater than at the beginning of the descending loop. Because along the way, you are reabsorbing any extra water from that interstitial fluid to keep the medulla concentrated. This is how it's maintaining that medullary gradient. How? It's focusing primarily on removing or reabsorbing any excess water in that interstitial fluid to keep the medulla concentrated. That's what you're seeing in this picture. We're looking at a vasa recta, and this is going to try to help to maintain that gradient. So it's going to want to stay close to that interstitial fluid concentration, where it's less concentrated close to the cortex and more concentrated closer to the medulla. So it will reabsorb or secrete sodium and water depending on what the change is in that interstitial fluid, because it wants to match it. And it turns out as you're approaching that ascending limb, it's going to reabsorb some water as it's approaching the cortex to dilute itself out. So you'll see larger blood volumes in that ascending limb as you're coming out towards that cortex side into a vein. While in the medulla area, it's going to be highly concentrated. It's just reabsorbing and secreting water and sodium to help to maintain this gradient. That's all that's happening. Otherwise, if you didn't have the vasa recta, your body will try to establish homeostasis. But you could keep it going thanks to these vasa recta trying to match the concentration of the interstitial fluid. So once you establish this medullary osmotic gradient, your collecting ducts will then take advantage of it. For example, there's when you're overhydrated. You drink a lot of water. Well, your body's going to send a lot of that water into the bloodstream, and you'll send it to the kidneys, where you'll pull out that plasma in the water. And you'll do your normal work of pulling that water out in the descending limb. Well, you're going to have a lot of water getting pulled out because you're overhydrated. So that interstitial fluid is going to become dilute. If it becomes extremely dilute, well, you're going to produce your production of antidiuretic hormone is going to decrease because you're having a lot of fluid in this interstitial fluid, a lot of water in this interstitial fluid. You're going to have a low sodium chloride concentration because it's dilute. Your body's going to notice you're overhydrated. Antidiuretic hormone production will decrease. You'll insert fewer aquaporins into the collecting duct and reabsorb less water. And that's how you're going to pee out more of the water. That's how you pee too much when you're overhydrated. This is how the collecting duct is using it, kind of in a roundabout way. It's really thanks to your production of antidiuretic hormone, but you're only going to produce this antidiuretic hormone if the interstitial fluid in the medulla becomes too dilute. Why? Because you drank too much water. You are overhydrated. And the opposite will happen if you're dehydrated. If you're dehydrated, well, then you're not going to pull out that much water in the nephron loop. You're not going to dehydrate the medulla. It's going to stay its nice and concentrated at 1,200 milliosmoles. And if that's extremely concentrated, well, then your body's going to notice it's concentrated because it's not a lot of water. You're going to release antidiuretic hormone, insert aquaporins into the collecting duct, reabsorb your water, and your urine's going to be concentrated. So that's really how the collecting ducts are using these countercurrent mechanisms. It's really thanks to whether or not you produce antidiuretic hormone. And you produce antidiuretic hormone depending on the concentration gradient in that medulla. Is it dilute or concentrated in the interstitial fluid around the cells in the medulla? And that's what you see in these pictures. In this first image, labeled A, you're seeing the overhydrated scenario. And when you're overhydrated, when you look at the interstitial fluid of the medulla, it's going to become dilute. And you're going to produce fewer aquaporins, produce less antidiuretic hormones, which will cause you to put in fewer aquaporins, reabsorb less water, and your urine will be dilute. While on the other hand, if you're dehydrated, in this image labeled B, is the dehydrated scenario, the concentration of the medulla will still stay high, which will cause you to release antidiuretic hormone, insert aquaporins into the distal convoluted tubules, cause you to reabsorb the water so your urine is concentrated. And luckily, you don't have to think about any of this. Your body's doing it all for you. And so now you know how you're concentrating your urine. But like always, there are things that could influence it. Now that you know how to concentrate or dilute the urine, we could talk about some things that are helping also, mainly urea. Your body, your kidney recycles urea. It's called the urea cycle, or part of urea cycle. You're just recycling urea. How? We already know we're going to secrete urea, pump it into the filtrate so you can pee it out in the ascending limb of the nephron loop. And it turns out you'll also reabsorb urea in the collecting duct. Oh yeah, some of that urea will leave the collecting duct and enter the interstitial fluid. Not all the way into the bloodstream, just goes into the interstitial fluid. Turns out, once it's in that interstitial fluid, it will make its way back to the ascending limb to get pumped back into the filtrate. You'll send it back to the collecting duct where it will leak back out into the interstitial fluid, and that's the cycle. Okay. You'll secrete in the ascending limb and it will leak out in the collecting duct. Why? Why are you recycling the urea? Well, the urea is also helping to maintain that medullary concentration, make it concentrated. Why? You're leaking out the urea in the collecting duct when the collecting duct is deep in that medulla. So it's leaking out in the medulla to keep the medulla in that 1,200 milliosmol concentration. So it's partly also helping to establish that medullary osmotic gradient. So it's not just you moving sodium chloride in water, but it's also some of this urea getting recycled. And one last thing that could affect your urine are diuretics. We talked all about anti-diuretic hormone. You remember we talked about diuretics before. Remember, diuretics are things that make you pee. And things that make you pee, diuretics are really anti-diuretic inhibitors. I know these names are crazy. They just prevent anti-diuretic hormone from letting you hold on to the water. So just think about what makes you pee. If you have a lot of it, it's things like alcohol. That's why if you drink a lot of alcohol, you'll pee because it inhibits some work of anti-diuretic hormone. Things like coffee, even certain medications. If you have high blood pressure, you might be giving what's called a loop diuretic to help you to pee. Why? Because if you pee, you'll lower your blood volume and lower your blood pressure. That's why certain people with high blood pressure get what's called loop diuretics. So diuretics will get you to pee. And the way they're going to work is usually by inhibiting anti-diuretic hormone. So remember anti-diuretic hormone. Remember anti-diuretic hormone forced aquaporins into the collecting duct so you would reabsorb water. Well, this will inhibit that, like alcohol. Or you could attack sodium. Remember, if you reabsorb sodium, you'll also reabsorb water. So if you want to pee out the water, if you want to be a diuretic, you can also inhibit sodium reabsorption. That's actually how caffeine is working. It's actually helping to inhibit some sodium reabsorption. Or if you're given a loop diuretic to control your blood pressure, the loop diuretics actually inhibit that medullary osmotic gradient. It prevents the medulla from getting too concentrated, so you'll pee out the water. So there are lots of substances that will get you to pee. There are lots of diuretics, and there's lots of ways to do it. Inhibit anti-diuretic hormone, inhibit sodium reabsorption, or inhibit that medullary osmotic gradient, and you will pee a lot. So now that you know all about how the kidneys help to make urine, concentrate the urine, regulate urine production, now we could put it to use. Remember, the reasons why we know anatomy and physiology is so that we could take advantage of it. So now you know really how to make urine. So now you know what should and should not be in urine, because you know what you should secrete and reabsorb. So because of that, we could study urine and figure out if there's things wrong with the body. When you examine urine for signs of diseases or disorders, that's called a urinalysis. When you go to the doctor and you pee in a cup, they're looking at your urine because that actually gives you a key as to what's going on in the kidney. They're doing a urinalysis. And I could see simple. Why? Because I know what I should not see. I should not see things that get reabsorbed. And I know what I should see in the urine because I know what I should secrete. For example, I know I should see some nitrogenous waste products. I should see some things like ammonia. Remember, that's that sodium and hydrogen compound. I should see ammonia because that's what gets secreted. And so if I see that, I see your kidneys are functioning. But on the other hand, if I see things like sugar in your urine, remember glucose is a sugar, glucose gets reabsorbed. I should not see that in your urine. If I see it in your urine, possibly there could be something wrong. So remember, at the end of this class, you're almost a baby doctor because you know a lot of what medicine knows, because medicine just knows a lot of anatomy and physiology. So let's go through some urine analysis. Let's examine urine and see what we can see and relate that to some kidney physiology. First up is something called the renal clearance. Again, don't be intimidated by the name. Renal, think kidneys, clearance, you're clearing something out. This is the volume of plasma the kidneys can clear of any given substance, meaning this is what your kidneys could pull out of the plasma within a given time. So let's say there's a certain medicine or drug in your system. This is basically how fast your kidneys could pull it out. That's the renal clearance. And your renal clearance tests are used to help determine your glomerular filtration rate, because this is basically that. It's how fast your kidneys could pull out something. In this case, something that's in the filtrate, in the plasma. So if you could calculate someone's clearance rate, you could also determine their glomerular filtration rate to help see if there's anything wrong with the glomerulus. And there's calculations. And that's what you see on this picture here. It's just the formula for renal clearance. It's C, represents the renal clearance, is equal to the concentration of the substance in the urine times the flow rate of the urine formation divided by the concentration of that substance in the plasma. You're basically saying, how fast can I pull it out the plasma? Concentration of the substance in the urine times how fast you make the urine divided by the concentration of the substance in the plasma. That's your clearance calculation. It's basically how fast can you pull out that substance. And that's related, or helps me to infer, the glomerular filtration rate. How it's related to glomerular filtration rate. If I notice, remember, your glomerular filtration rate on average is about 125 milliliters per minute. And your clearance is related to it, so it's also using the same units of measurement, and they're almost the same thing. So if I notice my clearance is less than 125 milliliters, I know that's really a low glomerular filtration rate. And if I have a low glomerular filtration rate, it must mean my substance is getting reabsorbed, because things are getting filtered slowly. That's going to give me lots of time to do reabsorption. Remember, think sodium levels. On the other hand, if my clearance is above 125 milliliters per minute, well, then I'm doing a lot of glomerular filtration. So I'm going to do more secretion than reabsorption. I'm not going to have that much time to do reabsorption, but I'm going to dump out my products. So this is going to help with secretion. Think if you're having a high glomerular filtration rate, it's going to help you to remove stuff. You're going to do more secretion. But what if my clearance is equal to 0? What if I have a glomerular filtration rate of 0? Well, it means nothing's being filtered. So everything is still in the body. You have complete reabsorption because it's still in the body because you never filtered it out. And if you have a clearance equal to 125 milliliters per minute, well, then there is no net reabsorption or secretion. You're pumping out, secreting just as much as you're reabsorbing. So when you hear clearance, think glomerular filtration rate, and there will be impacts on whether or not you're going to be doing full reabsorption, full secretion, or a mixture of both. And so we know these normal numbers. We know normal glomerular filtration rate and a clearance rate. So we could tell if there's something wrong. If your glomerular filtration rate falls below 60 millimeters per minute, there's something wrong. And if it lasts for 3 months or more, we call that a chronic renal disease because something's wrong. You're not doing your maximum filtration. Turns out you'll see chronic renal disease. You'll see a decline in your glomerular filtration rate when you have certain diseases like diabetes mellitus, high blood sugar, or hypertension, high blood pressure. And this is bad. You want to treat any renal diseases. Why? Because it could lead to renal failure. You're classified as having renal failure. Basically, your kidneys don't work if you have a glomerular filtration rate less than 15 milliliters per minute. Why? Because at less than 15 milliliters per minute, remember, this is close to zero. You're pretty much not doing any filtration. So whatever's in the body is still there. You're going to have toxicities. You're going to have stuff in your body outside their normal levels, like urea. Okay, things you need to get rid of, like the ammonia. This is bad. These are toxic. They will lead to things like nausea, vomiting, anorexia, pain, cramps, mental changes. You'll possibly be delirious because you're having these toxic levels of these chemicals in your body because you're not filtering them out. And so how do we filter them out? Oh, what does a diabetes patient need if their kidneys fail multiple times a week? It's dialysis. You're getting hemodialysis. You're going to have to do the work of the kidneys if you're in kidney failure. How are you going to do that? You're going to have to hook them up to a machine to do the filtering out of these toxic chemicals for them because their kidneys can't do it anymore. So just by studying urine, we know a lot because we know what should and should not be in there. Yes, you're going to reabsorb water, but we also know we could secrete it. So a lot of your urine is water. It's still a liquid. It's still mainly water. It's actually about 95% water. And the rest of the urine, about 5%, are just things dissolved in the water, solutes. So what are some of the things dissolved in the water? We already know. It's things we don't need. It's things like our urea, our uric acid, our nitrogenous-based products, and things like creatinine. These are things we should normally see in our urine. Why? Because they have nitrogen in it, and besides having it in our amino acids holding our proteins together, we don't really use nitrogen. So we'll eliminate it from the body. So we should see these nitrogen-based products. And depending on our ion levels, we may or may not see ions in it. Remember, if we have a lot of sodium, then we'll possibly pee it out. Same thing for potassium and other ions. We try to maintain an ion homeostasis. And if we need to, we will kick them out into the urine. And then we could see if there's any pathology, if there's anything wrong. There are things I should not see in your urine, like cells. Remember, in that glomerular filtration, there was the filtration membrane that prevented cells from crossing. So I should not see blood cells, red blood cells, white blood cells, or platelets in your urine. If I see them in there, there is something wrong. So remember, if you know anatomy and physiology, you know a lot about medicine. So if I check your urine and I see sugar in it, you might be diabetic. Or if I check your urine and I see blood in it, you might have something going on, some type of trauma. Maybe there was a burn, for example. Maybe you're undergoing hemolytic anemia and breaking down red blood cells and peeing out their byproducts. Or if I see white blood cells in your urine, maybe there's an infection. That's all this table 25.2 is telling us. Based off of what we see, we could figure out what's wrong because we know what should and shouldn't be in the urine. Going. We even know what color urine is. Your urine should have a slightly clear look to it, almost translucent, with a slight yellowishy pale look. That's it. That should be your normal urine, almost clearish yellow. Why? I want you to know what makes your urine yellow. It's a pigment. It's a pigment called urochrome. You get urochrome as a breakdown product of hemoglobin. Remember, when a red blood cell is dead, it hits its age limit, it gets broken down, and so does the hemoglobin. And another product you get from hemoglobin breakdown is urochrome, which will make your urine yellow. And so, if you have dilute urine, it will look paler because you're diluting the urochrome. Or if you have concentrated urine, it will look deeper yellow because you have less water to dilute the urochrome. That's all that's happening. So if your urine looks cloudy instead of clear, maybe there are cells in it, bacteria in it because you have an infection. If it's pale, maybe you're overhydrated. If it turns other colors like red, maybe there's red blood cells in it. It's just looking at it and comparing it to what we normally know what it looks like. Not only do we look at the color, we also look at or try to sense the smell. Your urine has an odor to it. Fresh urine should have an aromatic smell, kind of a fresher urine salt-based smell, and that over time it will turn into more of an ammonia-based smell. What's an ammonia-based smell? I'll just go downtown and go into an elevator downtown. You'll know that ammonia-based smell. That weird parking lot or parking garage urine smell, that's urine that's been sitting out. You'll smell more of the ammonia. But fresh urine doesn't have that deep ammonia smell. All right. And so if it smells like anything else, we could infer other possibilities. That's all that's happening. Keep going, other things. Remember, you could also secrete acids to help maintain your acid base levels. So your urine has a certain pH to it. Turns out your urine, because you could secrete acids, is slightly acidic. Has a pH around 6, not too acidic, around 6. Sometimes it could dip lower, more acidic, or be a little higher, a little slightly basic if you're a vegetarian somehow. Being a vegetarian, that would lead to a more alkaline diet, which will make for a more alkaline-based urine. So I could see, even just by looking at your urine, kind of infer your diet. So there's lots of things we could look at. Don't worry about specific gravity to help infer your renal system's health. All of that we just talked about was the kidney. Remember, most of this lecture was just about the kidney because that's the kidney's job is to do the job of the renal system. So like I mentioned way at the beginning of this chapter, we're going to finish off by talking about the other organs, the ureters, the bladder, and the urethra. But before we go into detail on them, you already know their basic functions. Ureters are going to drain urine from the kidneys and bring it to the bladder. Bladder is going to temporarily store the urine, and the urethra is going to drain the urine from the bladder into the external environment. That is their basic function. But we're going to look into them, break down their anatomy, remind ourselves where we find them in a little bit more detail. Starting off with the ureters. Again, you already know their function. The ureters drain urine from the kidneys and bring it to the bladder. And so you're going to find it close to the kidneys. Remember, where were the kidneys again? Remember, were they closer to the front of the body or the back? Remember, they were closer to the back. They're behind the peritoneum. They're in the retroperitoneal space. So because of that, the ureters are also in the retroperitoneal space. And we'll find them leaving the kidneys via that renal hilum, that little curved in section. The concave side of the kidney has the renal hilum, where we'll find things like the ureters. Remember, you know the order of flow of urine. The ureters really come after that funnel-shaped structure called the renal pelvis. And then, so you'll go after renal pelvis, into the ureters, and then the bladder. Turns out the ureters enter the bladder from the base and more from the back. They enter more of the posterior, inferior portions of the bladder. And I know what you're thinking. Why would you want to fill something up from the bottom? Why wouldn't you want to fill it up from the top? What was the actual good reason for it? Having the ureters enter the bladder from the bottom will help you to pinch off the ureters when the bladder is full. How? When the bladder fills up, it exerts a pressure. And that pressure will kind of squeeze and close the ureter to keep any urine from kind of going back up into the kidneys from the bladder once the bladder is full. So it's there to kind of prevent a backflow of urine. You don't want to send urine back into the kidneys. So the ureters will enter the bladder from the bottom. And when you look at the ureters, they're just a little tube. But even though they're just a tube, we've seen by now in anatomy, tubes have layers to them. Think things like blood vessels and lymphatic vessels. They have layers. Your ureters have layers also. I want you to know the 3 layers of the ureter from innermost layer to outermost. It's very similar to the layers of things like your intestines or a blood vessel. The innermost layer of your ureter is called the mucosa. Very similar to the innermost layer of intestines. It's called mucosa. And like your intestines, it's going to be epithelial tissue here. And you might know from A&P 1. You remember what epithelial tissue lines the inside of the bladder and ureters to allow for stretching? It was transitional epithelium. Lining the inside of your ureters in the mucosa and the mucosal layer is transitional epithelium to allow it to stretch. But then there's a middle layer. The middle layer is called the muscularis layer. We've seen that. Muscularis for muscle. In this case, it's smooth muscle, just like any other vessel. And that smooth muscle is still helping to allow for some movement. In this case, this smooth muscle is helping with wave-like contractions of smooth muscle we call peristalsis. And that peristalsis is going to help to push the urine through the ureters into the bladder. And then the outermost layer is just some connective tissue. It's connective tissue we've seen before. It's just some adventitia. Those are the 3 layers. Inner layer of epithelial tissue, mucosa. Middle layer of smooth muscle, muscularis. And the outer layer of connective tissue is the adventitia. Here's again a microscope image to help with lab. We're looking at a microscope image of the ureter. It's a tubular-based structure, so in the middle, the white space looks like a weird little octopus, lots of limbs reaching out. You're looking at the lumen. It's all the white little spaces in the middle. Then surrounding the lumen is a layer of transitional epithelium. That's the mucosa, kind of purplish blue color. Then all this kind of light blue color to the mucosa is some connective tissues, like they're staining the collagen fibers blue. You're looking at the lamina propria. That's just connective tissue. Think collagen of the mucosa. They just happen to stain it blue. Then move further out, you see these islands of purplish blue. That's just smooth muscle. That's the muscularis layer. And the outermost layer, you see that light blue again, because we're back to connective tissue. That's adventitia. So that's a picture of a ureter. And then after the ureter comes the bladder. And you remember the bladder is just temporarily storing the urine. And again, just follow the pathway of urine. Everything is located in the retroperitoneal space. So is the bladder. But it's on the pelvic floor, bottom of the pelvis, but still closer to the retroperitoneal space. It's behind the pubic symphysis. And in males, you got to account for other structures, and in females as well. In males, they also have a prostate. Turns out the prostate is right below the bladder. It is inferior to the bladder. Little round ball-like structure right below the bladder. In males is the prostate. Females do not have a prostate. Females, on the other hand, have a uterus and vagina. The uterus and vagina are behind the ureters, behind the bladder, sorry. So if you were to think about it, the urethra will be anterior to the vagina because the bladder is anterior to the uterus. And this is anatomy. We name lots of random places. There is something called a trigone. This has to relate to the internal anatomy of the bladder. If you think about it, the bladder has 3 holes in it. It has a hole where one ureter will drain and another hole for draining another ureter, right and left ureters. And there's the hole that allows the urine to leave the bladder or into the urethra. If you were to connect the 3 dots, the hole for the right and left ureters and the hole for the bladder, connect the dots, it will form a little triangular shaped area we call the trigone. Why do we care about the trigone? Why do we care about this area towards the bottom of the bladder where all these 3 holes are? Well, it turns out due to gravity, because it's towards the bottom of the bladder, urine and things dissolved in it will settle there. Well, you tend to have infections here. Infections persist in the trigone. Infections tend to exist in that triangle area where you see all these openings. But no matter what, we got to keep going. Bladder, like any other organ, can get broken down. It's hollow in the middle, so it's almost like a big tube because it's still open. It has holes to it, so it's almost like a tube. So it has layers to it. Turns out your bladder, like the ureters, has 3 major layers. In order from innermost layer to outermost. Innermost layer is still the mucosa. And this is bladder, so it's still going to be transitional epithelium there. It's going to have a middle layer of smooth muscle. It's going to have a muscularis layer. And it will have an outer layer of connective tissue. It will have an adventitia. But in that middle layer, in the muscular layer, we name the muscle. All the smooth muscle in the muscular layer of the bladder is called the detrusor muscle. Your detrusor muscle is just the middle layer of the bladder. It is the muscle in the bladder. And when this muscle contracts, it helps the bladder to expel the urine, helps you to urinate. When this muscle contracts, that's when you feel the urge to urinate. And you don't control that urge feeling. How do you know? Try it now. You can say urine urge activate. It doesn't happen. Why? Because you don't control the detrusor muscle. Why? Because it's smooth muscle. And you remember smooth muscle is involuntary. So that's a little bit on bladder layers. Innermost layers, still transitional epithelium, helping it to stretch when it fills up with urine. Detrusor muscle is the middle layer. It's all smooth muscle. It will contract to help empty the bladder. And the outer layer is still adventitia, still connective tissue. And that's all you're seeing in this image. You're seeing it in the male in this image. You're seeing the bladder is the large circle up top. You're seeing the 2 ureters kind of coming from the top, and you see their holes for insertion towards the bottom. You see the opening for the urethra towards the bottom, and you see they've outlined the trigone area. This is a male. How do I know? I see the round circular structure, the prostate, located right inferior to the bladder, and then you see the penis down below. And then here's a zoomed in image of just the bladder again, showing the ureters up top. You're seeing there are 2 openings down below and the opening for the urethra, and you see the trigone area. Then you're seeing the urethra, and you're seeing some muscle surrounding the urethra called your external urethral sphincter. And towards the kind of the bottom of the bladder, you're seeing the internal urethral sphincter. Those 2 sphincters are going to help to control urine flow. So that's a little bit on some bladder anatomy. And so again, there's the physiology. Your bladder is simply storing urine. And so it needs to be able to fill up and empty like a balloon, kind of like the stomach. Oh, you remember the stomach had something to help it fill up and stretch. Remember when we cut open the stomach in AMP1, we saw rugae, those little folds. They were there to help the stomach expand when it fills up with food. Well, the bladder needs to fill up with urine. And yes, it has transitional epithelium to help it to stretch, but it also has rugae. There are also rugae in the bladder to help it to fill and stretch with urine. And we even know how much the bladder could fill up with. On average, the bladder usually holds about 500 milliliters of urine, about a pint. And if it had to, it can almost double that amount in extreme circumstances. But you don't want to try to double that amount. You don't want to try to hold a liter of fluid. You might over distend and possibly perforate the bladder. And again, there is muscle in the bladder. Once you're ready to empty the bladder, it's going to be that muscular layer. It's going to be that detrusor muscle that will help to contract. And the innermost layer of the bladder is going to have that transitional epithelium. And then after the bladder comes the urethra. And again, the urethra is another tube made up of layers. It will also have a muscular layer of smooth muscle. And that's going to help to move the urine. It will also have an inner layer of mucosa, except it's going to be a mix. Turns out when we look at the mucosal layer of the urethra closer to the bladder, it's going to look similar to the bladder. It's going to be transitional epithelium closer to the bladder. And when we look closer to the external environment, your urethra comes to an end as an opening we call the external urethral orifice. It's going to be closer to the external environment, which is skin, which is stratified squamous epithelium, except non-keratinized. But everything else in between is going to be pseudostratified columnar epithelium. So your urethra is kind of weird. It's pseudostratified columnar epithelium, except closer to the bladder, it's transitional, and closer to the external urethral orifice, it's going to be stratified squamous. And then we need to control flow of urine through the urethra. I kind of showed you two sphincters, two bits of muscle to control whether or not you pinch off the urethra and restrict urine flow, or you dilate it to allow for urine flow. Yeah, I want you to know these two sphincters and which one you control. There's the internal urethral sphincter and the external urethral sphincter. What's going on? The internal urethral sphincter we saw in the picture prior to this was kind of closer to the base of the bladder, while the external urethral sphincter was closer to the floor of the pelvis. Turns out that internal urethral sphincter, because it's basically is the floor of the bladder, it is still smooth muscle. So you don't control it. You do not control the internal urethral sphincter. While the external urethral sphincter, closer to the pelvic floor, that's all skeletal muscle. So you control the external urethral sphincter. So when you're running to the bathroom and you're trying to hold it, you're really holding or contracting the muscle of your external urethral sphincter to pinch off and close the urethra. So if you ever pee on yourself, you can't blame anybody else because you hold the last door. You hold that external urethral sphincter. So if you want to urinate, it's your body involuntarily relaxing the internal urethral sphincter, contracting the internal urethral sphincter to open it. And it's you voluntarily controlling the external urethral sphincter to open up that external urethral orifice and allow you to urinate. So that's a little bit on the urethra. And if you were to look at the urethra in males and females, it's not really the same. Turns out in females, the urethra is really short. On average, about 4 centimeters. Not that long. While in males, if you were to look at the urethra, it is closer to 20 centimeters. Why? You got to think it has a longer route to travel because it has to go through the penis. So in males, when we look at the urethra, in males, we have to break it up because it's so long. I want you to know the 3 parts of the urethra in males. There's the prostatic urethra, the intermediate urethra, sometimes called the membranous urethra, and the spongy urethra. That's the order of flow for urine when you're going through the urethra in males. And it kind of makes sense when you look at a picture like this one here. Remember, it's just the order of flow of urine. After the bladder, you enter the urethra. And you know from our previous images that right below the bladder in males is the prostate. So you can see in this image, part of your urethra passes through the prostate. That's what we call the prostatic urethra. Then after the prostate, you're basically at the floor of the pelvis. And at the floor of your pelvis is a little muscle we call the urogenital diaphragm. That's what you're seeing in the image. It's the little flat pancake-like muscle. And you can see some of it surrounds the urethra. So that part of the urethra passing through the urogenital diaphragm is what we call the membranous urethra, or the intermediate part of the urethra. And then the rest of the urethra is going through the penis. It's passing through what we call the spongy part of the penis. So we call this the spongy urethra, sometimes called the penile urethra, and it will end at that external urethral orifice. So those are the 3 parts of the urethra in the male. And now that we know the organs, the last thing we finish off with is the process of urinating. We got to talk about just how do you pee. The process of urinating is called micturition, or simply urination or voiding. Remember, there's lots of names for everything. You call it peeing, urinating, voiding, or micturition. And it turns out There are 3 events that need to occur for you to pee. They all need to occur at the same time. 3 simultaneous events. And it makes sense when you think about it. For you to pee, you need to empty the bladder. And to empty the bladder, you need your detrusor muscle to contract. But it's smooth muscle, so you're not going to do it. Turns out your autonomic nervous system is going to do it. Turns out it's your parasympathetic division of your autonomic nervous system. Remember, that's rest and digest. You could pee with it. So for you to urinate, one of the things that needs to happen is your autonomic nervous system needs to stimulate the detrusor muscle to contract, squeeze the bladder, and empty the urine. But for you to pee, you need to open up the urethra. You need to open up where those 2 sphincters are. Remember, the internal urethral sphincter is smooth muscle. You don't control that. So it's going to be autonomic nervous system that will get it to contract and open up. While you're going to run to the bathroom and use your somatic nervous system, the part of the nervous system you control, to get the external urethral sphincter to open up. So all 3 of these things need to happen at the same time for you to pee. You need to contract the detrusor muscle, autonomic nervous system. You need to open up the internal urethral sphincter, autonomic nervous system. And you need to open up the external urethral sphincter, which is what you're going to consciously do with your somatic nervous system. But how does it all begin, especially for people who can't really control stuff? Who can't control when they urinate? I'm talking about babies. All those little babies. They don't know how to do anything. Little babies don't even know how to hold their pee. So how do you do what's called reflexive urination? How do infants pee? Because they're not thinking about it. They're just peeing in a diaper. Turns out it's their body, like usual, doing things for them. When their little baby's bladder fills with urine, it's going to stretch. And like usual, when things stretch, there will be receptors to notice the stretching. This almost sounds like a reflex, because this is reflexive urination. So once the receptors notice the stretching, they're going to use a neuron, in this case, parasympathetic neurons, to go and talk to the spinal cord. Remember, that's where your integrating center is. And your spinal cord is going to use a motor neuron to talk to muscle. What muscles help us to urinate? It's going to be in a muscle in our detrusor muscle and in our internal and external sphincters. So when that little baby's bladder fills with urine, it's going to stretch. Receptors are going to notice the stretching. Parasympathetic sensory neurons are going to tell the spinal cord. Spinal cord is going to use a motor neuron to tell the detrusor muscle to contract and the internal urethral sphincter to contract and open. And at the same time, you're going to inhibit the somatic pathways because the baby's not thinking about it. And this will lead to the opening of the external sphincter. So that's how little babies are urinating. They're not thinking about any of it. It's all thanks to a reflex arc coming into play for them to help them to empty the bladder. Why? This is going to change over time. Turns out this needs to happen as a reflex for babies because their brains aren't done developing, especially parts of the brain that are responsible for urination, responsible for micturition. It's the pontine centers. And these pontine centers, on average, don't mature until around age 2 or 3. This is why you don't want to train your kid to pee until around ages 2 or 3. So if you hear a mom or a dad talking about they train their baby to pee in the potty at 6 months, they're lying. Just be like Houseway, their brain isn't even ready yet. Okay. So how do these 2 centers help you to urinate? Well, there's the pontine storage area. So it kind of gives you a hint. You're going to store the urine. And there's the pontine micturition center. Gives you a hint. It's going to do micturition, pee. So the pontine storage center, tells you in the name, it's going to inhibit micturition. It's going to inhibit that parasympathetic division of the autonomic nervous system and stimulate the sympathetic so you'll hold on to the urine in the bladder and not pee. This is how you're holding your urine. And then when you're ready to go pee, you'll use the pontine micturition center. This will stimulate the parasympathetic nervous system and inhibit the sympathetic, so you do pee. So this is what you're waiting to mature so you could train your kid. You're waiting for that pontine storage area to mature so they could hold it, and the pontine micturition area to mature so that when they hit the bathroom, they can go. And that's how your urinary